Hi, I'm Stephen Bruce. I run the Academy of Physical Medicine, and here's 45 minutes of free CPD for you. This is just an example of what we do. We run a free session every month, along with 70 plus hours of live learning with others CPD every year. If you'd like to see more, click the link in the info section below the video, and that'll take you through to our website. Enjoy. Good afternoon. Great to have you with us for yet another 45 minutes of lunchtime learning. I hope you're warm where you are, because it's bloody cold in the studio here at the moment. Somehow the fuses tripped on the heaters and nobody noticed until 5 minutes before we went live. Anyway, we are here now. We're down to just 2 more shows after this before our Christmas shutdown. We're looking at neurological testing on Wednesday evening in a couple of days' time, and then we've got a lunchtime case-based discussion at lunchtime on Wednesday the following week. So hopefully you'll be able to join me for both of those. That will take us to 63 hours of learning with others delivered by the Academy this year, not including our face-to-face courses. Do you know, I'm quite proud of that. Anyway, today I've got a very popular topic for you, vestibular rehabilitation. My guest is Alan Seeley, a specialist physiotherapist who's over 20 years experience in dealing with the problem. Good afternoon and welcome to you, Alan.
Good afternoon, Stephen. Nice to be here.
Yeah, I think it's a bit colder where you are, isn't it? You're up in Aberdeenshire at the moment, so you've even got snow, which we haven't where I am.
We have an inch or two of snow, and it was about -10 a couple of nights ago.
Yeah. Anyway, let's get on to the topic in question today. You're an expert in vestibular rehab. How comes that? You've had 20 years of it, I think?
Mm-hmm. Yeah, I'm a manual therapist in background, and I trained in Sheffield in late 90s. And just like many things, by chance, ended up working with an audiological physician at the time in Sheffield, and through him developed an interest in the field and ended up taking that abroad. Worked in Oslo for a while. I was invited to start a balance clinic in Oslo in the early 2000s, and so moved over there. And really, through my time there, I was able to work with a lot of the leading clinicians in the field, probably through the early 2000s, and developed a lot of experience, a lot of interest, and took it on from there.
Yeah, we have done a little bit about BPPV mainly on the show in the past, and we've had people on to demonstrate the Epley maneuver and so on. I think what you do goes beyond that, doesn't it?
Well, remember, BPPV is just one trigger, one of the many triggers for dizziness. And so, yeah, the Epley and other maneuvers are very, very effective at treating benign positional vertigo, but they won't have any effect on anything else, on any of the other triggers for dizziness. So that's just one of the tools that you would use. Yeah.
Didn't you have, I think I saw in your slides, didn't you have an interesting quote from a doctor in the 1960s about dizziness?
Yes, simply that... dizzy patients get a bad do. If you pop the slide up, I can't remember the quote off the top of my head, but you have to put the slide up.
Slide 1, that is.
Number one before that.
Oh, right,
yeah, I mean, it's a lovely old quote. It dates from the 60s, before I was born. And if we read it out, there could be few physicians so dedicated to their art that they do not experience a slight decline in spirit when they learn that their patient's complaint is dizziness. And the reason I kind of highlight that as a quote is because nothing's changed. That's sort of 60 years ago, and nothing's really changed. And can dizzy patients get a bad do? They generally don't get well treated, and they don't get the effective treatment they need, which is a crying shame, because there's a natural recovery for most dizziness. There is a natural recovery process. And the reason some people don't get better is not because they can't, it's just because they haven't been doing the right things. Instinctively, people often put barriers to recovery in the way, and as a therapist, often all we're really doing is removing obstacles to recovery.
You're definitely preaching to the converted with that line for the osteopaths and chiropractors in the audience, because I have hammered into us, I think, during training, that we're just putting the body in a position where it can heal itself rather than actively doing something to it to make that healing happen. You said you went to Oslo and worked there. Did you find that their approach to treating dizziness was better in Scandinavia?
Back then it probably was. I think at the time a lot of good research was coming out of Sweden and Norway. I was fortunate in that I was working in a very exclusive sort of private clinic at the time. It was a chiropractic clinic. And I was fortunate because we were able to get clients very early. So I was able to see clients, within the first week of onset of dizziness, which is pretty unusual in the UK. And then because of that, they were getting the right intervention at the right time, good combination of sort of medical intervention with appropriate medications, audiological assessment, and myself doing the rehab. So it was just a convenient way of seeing people.
Yeah. Obviously, early intervention is good for any problem. Is it detrimental in other ways to delay the intervention, to delay your rehabilitation? Does it make it more difficult or impossible to recover?
To some degree, it doesn't make it impossible, but it does tend to lead to more compensation. So you get more inappropriate compensations or altered motor strategies, altered behavioral patterns will start to kick in the longer something goes on. But ultimately, no, it doesn't stop people recovering. It just delays things and people become rather disabled in that period of time.
So what now is the course of treatment in the UK? I mean, what would be the patient journey, to use that awful expression? They go to their GP, they say, I'm feeling dizzy. What happens to them then?
Well, probably the GP will sort of, most importantly, make sure it's nothing serious. That's the fundamental role, isn't it? Rule out the red flags. But assuming it's nothing serious, then they may well give them some medication, typically sort of prochlorperazines, snarazines, or common names, Stemetil. And this is really just to stop them being sick, because there isn't a medical, a drug, pharmaceutical treatment for dizziness. Although most people do get drugs, they don't really work long term. They're just going to stop you being horribly ill to start off with. So you'll probably be given a medication and hopefully told that it will get better by itself. And it should. The vast majority of people, that's not true. 50% of people will get better by themselves.
Over what course of time?
Over a relatively quick period of a few weeks, a couple of weeks or so, something like that. And that's what we'd expect. But half the population probably don't. And the reason they don't is generally because they start to do the wrong things. And recovery depends upon the brain getting a lot of feedback. And the feedback, means really signals from the eyes, the ears, and the vestibular, and the neck, and proprioception from the rest of the body, but particularly the eyes and the neck. And in practice, that means movement, movement of these bits of the body. And if you move, you'll generate enough feedback for the brain. The brain will work out it's getting it wrong, and it can sort the problem. But that means doing things which make you feel dizzy, and that's scary and it's unpleasant, and so people avoid it. And so then they fuse up around the sort of the neck and the shoulders. They become very stiff. They don't move the head, or if they do move the head, it's eyes and head and trunk. Everything's moved together as one, a bit like a lighthouse or something. And so the brain doesn't get the feedback it needs. And then that's when you end up getting these more chronic dizzinesses.
Okay. It must be quite challenging with patients, encouraging them to do something which might make them feel sick or make them feel, or encourage vertigo, for example.
Indeed, yeah, and it is, and that's why they have to understand the situation. But yes, you are ultimately asking somebody to do something which is not very nice. But I always like to equate it with physical training. It's just the same as getting out of breath. If you want to get fitter, you have to get out of breath. If you avoid getting out of breath, your heart and lungs, musculo-skeletal system will never ever sort of improve, and it's that kind of a thing.
You mentioned GPs excluding red flags earlier on. Which particular red flags did you have in mind?
Well, with something like an acute onset vestibular condition, a dizziness, a sudden onset dizziness, you'd really be thinking stroke. Yeah. So that would be the most important thing. But otherwise, cerebellar problems and possible tumours, but they will be more gradual onset. But mostly it would be stroke.
I have to say that dizziness is not one of those characteristics that is commonly associated with stroke, is it? It's not part of the FAST test or anything like that?
It's about 5%. 5% of people with stroke are dizzy. So no, it's not the most common symptom. It's not what you'd expect. But
so does that mean that it could be the only symptom of a stroke?
No. If you've had a stroke causing you to be dizzy, there will be other brainstem signs. There'll be other central signs. Okay. For sure.
Right.
Yeah, absolutely. So as long as you're following your normal sort of, your normal red flag pathways and things, you will find you'll be fine. You pick up these things.
Yeah. All right. You mentioned that 50% of people will get better in the course of a couple of weeks if they're lucky. What happens to the 50% who don't under the current NHS pathway?
They will ultimately be referred to ENT, but unfortunately that's a long waiting time nowadays. So
Right.
they tend to sort of be pushed around the system basically and end up sort of going to ENT. And the nature of dizziness is that by the time the client ultimately ends being seen by the specialist, almost invariably the pathology has probably settled down and gone away. And so
Right.
often you don't find really hard signs of pathology or disease, as it were, or damage.
Right.
And it's more the compensations or the way the body is adapted, which will maintain some symptoms. And so then
Okay.
they tend to go through a cycle of sort of looking for these diagnoses which no longer exist. And that's where, they go and see the doctor, the ENT, the specialist, the neurologist, they have a scan, and nothing is being found. And so you end up with this horrible sort of treadmill where everyone's telling the patient what they haven't got, and nobody's actually sitting down with the patient and saying, yep, this is the problem. You've got a chronic dizziness which hasn't got better. This is what you now need to do about it. And that's where the rehab comes in.
So, just where do you personally fit into this pathway at present? As osteopaths and chiropractors, we often struggle to get GPs to accept that we have any skills worth knowing about. As a physiotherapist, I imagine that you're more readily accepted to them. But are you someone to whom they would refer straight away rather than wait the months and months and months before they can get to a consultant?
It very much depends upon the individual in question. I mean, where I work, I'm working entirely privately at the moment, so I'm not within the NHS system. However, the doctors up here know me, and so they will tend to send their clients to me, which is fine. But the patients have to be prepared that it's a private service now. Yeah.
Yes, I think patients are becoming more and more accustomed to having to pay for their treatment these days, aren't they?
Sadly, just because of the demands on the NHS, yes, and the delays involved that the service offered, although absolutely fine once you get to it, it's just getting to it is the problem, which is the issue. Yeah.
Well, Caroline's just sent in a comment saying it's a 12 months plus waiting list for ENT in Cumbria at the moment. That's hideous. 12 months,
Yeah.
good Lord.
And that's relatively common. And the thing is, in that 12 months, whether it was a crystals or whether a BPPV or whether it was a viral thing which triggered or a migraine attack, almost invariably the condition, the trigger for the problem will have settled. And that's often the way I like to think about these things is what was the initial trigger for the problem,
Yeah.
for the dizziness, but then accept that the trigger may well have gone and we're looking at the effects. And so you work with the effects with the patient.
Yes, yeah. Just before we go on, Christina Ann has sent a comment in saying that she had a patient who regularly contacted her to say that she was, quote, off her rocker, unquote, again. And in this particular case, she found that adjusting her atlas axis gave miraculous, almost instant results. The dizziness disappeared. Are you yourself, do you manipulate joints as well?
I do, and I'm a manual therapist trained with manipulative therapy as postgraduate training through the physio world. But although in practice with many of my dizzy patients, I don't because of their age and just because of the mix of symptoms they often will come with. I tend not to use the high velocity thrust manips
Right.
the neck as much, mostly because I find I don't need to. So soft tissue release and sort of more gentle work around the neck will often be enough.
Yes. Yeah.
However, there's no problem with these things. If you're competent and comfortable doing them, then that's fine, and they're indicated.
No,
As long as
absolutely,
we
and I think of course it does depend on what the cause of the problem is. Peter has sent in a comment saying that the Epley manoeuvre helps with dislodged otoliths if that is the cause of the dizziness, and we were going to talk about Epley manoeuvre at some point during this show, weren't we? Before we do that, before we do that, we mentioned two causes of dizziness: BPPV and now stroke. What are the other principal reasons that people suffer dizziness that we might encounter?
Well, by far the most common is BPPV, and that's the one always to be looking out for. But if we then sort of bring it down to, okay, vestibular, let's ignore the central serious pathologies like stroke and minor tumours and things. So we're looking then at anything which is going to trigger what we call a hypofunction or a unilateral hypofunction. So where one side is weaker than the other side. Okay, and that would be something like it could be a vestibular neuronitis, which is an irritation of the nerve between one inner ear and the brain. And so the signals are not getting into the brain on one side. But it could also be, classic labyrinthitis, where you get infection of the whole inner ear and you lose hearing as well. You could have bilateral loss of function, so both sides are down, maybe due to sort of some major infection or ototoxicity from drugs, for example. You can have conditions called Meniere's disease, which is less common, probably only about 5% or so. And it was frequently overdiagnosed in the past. But that would also, again, be a condition going on in the inner ear, causing temporary imbalances between the two sides.
Yes.
And then the other big one would probably be vestibular migraine as a trigger. And migraines are common and they're benign and they leave no trace. But again, it's just a central imbalance. So one side of the brain fires away, causing imbalance within the balance system.
Do you have a role in all of these cases, or only BPPV or mechanical causes?
No, I think I have a role in virtually every source of dizziness, as long as we've ruled out stroke. And even if we have got stroke, once the patient has been stabilized and on the drugs and everything, then yes, there's no problem working with these causes as well. So really, anybody who hasn't got better needs rehab. That's the fundamental, because the potential for rehab is good. And if it's a peripheral condition, as long as the brain is okay, the potential for rehab is extremely good. You should get better, and that's the key thing.
Does that mean that you get good results with stroke patients who are perhaps not getting better as a result of standard post-stroke care?
No, not particularly. No. But I would say that if dizziness and vertigo is one of the symptoms of that stroke, then remember it's not a common symptom of stroke. Then yes, the patient can do well. So peripheral conditions, prognosis is very good. Central conditions, the prognosis is good with dizziness, but it's slow. It's not going to be fast. The thing that's bad news is if you have a mix of peripheral and central conditions at the same time, because you need a good brain to compensate for a vestibular imbalance, so the brain can reset the system.
So how does the diagnostic process work there then? How do you know which is which?
It's relatively straightforward. If any stroke causing dizziness, well, there will be other eye signs. So I'll go through sort of oculomotor function tests, basically looking at smooth pursuits, saccades, optokinetics, cranial nerves, because you will see, looking at how the eyes move, looking at the patterns of nystagmus that we'll see in the eyes, we can diagnose central from peripheral relatively straightforwardly. So I'm fortunate. I work with a sort of set of video ocular goggles and equipment which the patient will wear, so I can see how the patient's eyes are moving very, very clearly.
Yeah.
You may not have those when you're in your own clinical practice if you don't see many dizzy patients. But even without them, you can still readily identify serious pathology by looking at how the eyes move. So oculomotor functions are crucial.
Okay. Earlier on, you said something about in many cases you wouldn't use high velocity techniques because of the age of the patients. And Dawn has does vertigo get more common with age? If so, why is that? And what can we do to prevent it getting worse?
Dizziness and vertigo generally does increase as we age. Most things get a little bit worse as we age. Proprioception goes down, vision goes down, and likewise the vestibular inputs, the sensory systems deteriorate as well. Relatively less than the others, though, and they actually are maintained quite well. But things like crystals, the BPPVs, they become more frequent occurrences as we age, because the crystals are crumbling and fragmenting more the older we are. So the older you are, the more bits of crystal you have floating around in the otolith, basically. So that's one reason. And I think also the other main reason is just you've been on the planet long enough or longer, so you're more likely to have attracted or picked up vestibular conditions. Because one of the things that goes on is, the vestibular conditions are really common, very, very common. So there's a high likelihood that at some point in your life you will have an imbalance, causing you to be dizzy. But remember, there's a natural recovery, and the brain should compensate from that. Often it doesn't. Often you will just compensate in ways that will mask the problem rather than actually dealing with the problem. So, for example, patients will stop moving their head, they'll keep their head very still, and they'll just tone up in their neck instead. And so the neck muscles, the upper suboccipital muscles become very, very tense, very tight. And that may well mask the underlying imbalance and means they're not particularly dizzy, but then they may go on and get neck problems and headaches and the like. Or it might be that you start to use your vision as a way of compensating. So you go the opposite way to a blind person. So whereas a blind man, obviously, a woman obviously does not use their vision for balance, you do. And so you start depending on visual reference points to help you keep upright. And you're fine in the daytime. And if you've got a nice horizon or vertical building to look at, no trouble. But in the dark or at night, you're likely to be very wobbly, very unsteady. And these compensations will carry on through life. But then what happens when the compensations fail? As you get older and your eyesight goes, that's going to leave you very, very vulnerable. And that's indeed what happens. When you look at the elderly population who fall, for example, you'll find they actually have underlying vestibular conditions which have just been masked by vision or by using their proprioception. Right.
Interesting that. I suspect we've all got patients who have complained that as they're getting older, they're getting dizziness. And in many cases, I suspect that they're not getting any diagnosis of any value from anyone other than maybe the GP saying, well, it's just a function of age. Yeah. It sounds as though there is some hope for them.
There's always hope in terms of dizziness, and even if it's an 80+ person coming in and they're dizzy, I'm always quite confident that we'll be able to get some improvement, even working within the frame that the bodies are 80+ and they've got poor proprioception and vision and muscular strength and everything. But there's always good room for improvement.
I want to get on to some more specifics from you about rehab in a minute, but the questions are coming in. Cookie has asked whether cases of vertigo have risen since COVID.
I would say no, because they've always been common, so they're still common. I don't think it's significantly changed. And what is true to say is that I do see quite a lot of clients who come in whose symptoms have been flared up or triggered by either having COVID or some other flu or bug, and or the COVID JAGs. And it's really important to emphasize there is no direct link between either COVID and dizziness or having the inoculation and dizziness. There's no connection. But having any other illness is going to run the body down, it runs the immune system down, and so you're quite likely to become vulnerable then to having a flare-up of any dizziness. Yeah. So I mustn't sort of say don't get your JAGs and don't get COVID and things. There's no connection, absolutely none. Right. But it is the case that people do report increases of symptoms. Yeah.
Someone who I'm being told is called Santa's little helper says, I had an attack 3 months ago, an acute attack 3 months ago, presumably of dizziness, and was just encouraged to do online research for home remedies. The GP was very apologetic in telling me this, and yes, pulled me in after a telephone consultation face-to-face to check for stroke and diagnose BPPV. I think that would be discouraging for anyone, being told to go online and look for home remedies, wouldn't it?
Yeah, no, that's fairly typical, sadly, is that people are just not getting access to the help they need. And really, if after a couple of weeks things are not significantly better, you have to go back to the GP again, and you have to sort of really ask and hassle for referral to somebody who knows how to do the rehab. But that again is a problem because there aren't that many people out there who know how to do the rehab. So there's a big gap there.
Yeah. We've had another question about long COVID and its relationship to ongoing dizziness, but I think you've answered that one already. There is no direct connection between the two. Go on.
I was just going to say, other than that, anything like these long COVID conditions, or they will cause an increased sensitization within the nervous system. So the nervous system is now, reacting inappropriately to relatively ordinary inputs coming in, and hence we get rubbish outputs, basically. Yeah.
Can we get onto some specifics, as far as is possible in a short show like this, about what your approach is to the problem, then, Alan?
Number one, it's really to look at the patient. I think in the past, sort of vestibular rehab has got a bit of a sort of a poor judgment because people just used to give lists of exercises. Like anytime, if you give a list of exercises to somebody, it's better than nothing, but it's really not very effective. And the most important thing is to actually base your intervention on the person right in front of you, which is obviously what you guys as osteopaths do most of the time anyway. And so I tend to look at my assessment, and I'm looking for dysfunctions, so things that the patient can't do, or things that are not working well. So, for example, eye movements or whatever, and or looking for things which provoke symptoms. And so then you pick one or two key movements or symptom provocations, or one or two key dysfunctions, like, for example, the ability to follow a moving target with your head, for argument's sake, and just give the patient these 2 or 3, 4 key things to work on. And like anything in the body, if you work on something, it gets easier. You practice it, it becomes more straightforward. And so they then get easier and will become asymptomatic within a week or two. And then you progress to another thing. You find something else that the patient can't do, or something more challenging, or you make the exercise harder, or you just keep on pushing on, homing in on the problem as best you can.
And are these techniques you've developed yourself, or are they the basis of in-depth randomized controlled studies?
No, it's vestibular rehab has been around for a long time. These are sort of quite well-established ideas, and probably all I do that maybe some people don't is just sort of pull different strands together from different areas, rather than just religiously following the vestibular pathway or the musculo-skeletal pathway or the neurological pathway. I tend to pick things, from each, because we're all trying to really restore normal movement. However we do that doesn't matter. But in restoring normal movement, we're restoring normal proprioceptive feedback to the brain. So everything is going to be a lot easier for the brain to work out.
Yeah.
Yeah.
Pep has asked about tinnitus. Is that something you get involved with as well?
Yes, but again, indirectly. I mean, that's a whole other topic in itself. But a tinnitus, again, is just it's a brain sensitization. It's a reaction to something that's happened. And it goes along with some of these vestibular conditions, because if the inner ear is not working very well, then the brain will tend to crank up the volume. It cranks up the intensity. You become more sensitive to signals coming in from that side. And so then you'll start misinterpreting your cervical signals or your jaw signals as signals from the ear. And therefore the brain starts to perceive sounds which aren't there. So yes, I do work with tinnitus a lot, but it's an indirect sort of function of a problem.
Right. But you get results with it. You can improve the problem.
You can do, yes. Again, but it depends. It's one of those things, though, that the patient has to understand the sort of the pathophysiology, if you like, and the fact that if it's a perceptual thing and they're paying too much attention to a signal which normally the brain would filter out.
Yes.
So if I say to the patient, "Don't think about elephants," it's not going to work, is it?
No, not at all.
You have to get the patient thinking about, I don't know, screwdrivers or sausages instead. And as long as the patient's focusing on the screwdriver, they're not going to focus on the elephant.
Yeah. Well, you mentioned labyrinthitis earlier on as well. And in my experience, my limited experience of dealing with this, the patient concerned, I think, was prescribed antiemetics, and that was about as far as it went. What's your protocol there, and what's likely to be causing that problem?
Well, probably it's not a labyrinthitis in the first place, because unless they actually lose hearing as well, it's probably not a labyrinthitis. Yeah, that's the first thing. So labyrinth is the whole of the inner ear balance and hearing. So if you lose hearing and vertigo together, then yes, that may well be labyrinthitis. So if they only lose balance, if they're only dizzy, then it's more likely to be what we call vestibular neuronitis. So right. There you have a loss of function on one side of the system. Yeah. So for example, on my left side, the signals are not getting into the brain, and the brain has to reset that system, okay, which it can do, and the brain will just gradually reset, but it will only do it if it gets enough feedback, which means movement of the head, movement of the eyes, movement of the neck. In so doing, you will generate a mismatch, what we call a sensory mismatch between the different signals, because the brain will be getting the signals that I'm moving my head when I turn my head, and the eyes will confirm that, but the vestibular system will contradict that because it's wrong, because it's not working. And that sensory mismatch is what the brain needs in order to get it right, to improve it. So it's a bit like, I suppose more philosophically, we need to get things wrong in order to learn how to improve or get things right. But it's the same principle. But if you give the brain that feedback, then the brain will sort itself out. And that really just means getting the head and the neck moving again and getting the eyes moving again. And often you have to end up sort of doing coordination exercises between the eyes and the head just so things get a little bit sharper. But ultimately, it's get the head and the neck moving, and people will start to recover. And then you may well need balance exercise as well, because the dizziness is ultimately just a symptom of the balance system not working very well. And so you may have to get the patient balancing, whether that's on hard ground or soft surface, one leg or two legs, absolutely depends on the patient. But
and I presume that there's a progression in this, particularly with labyrinthitis, where it's quite scary for the patient. You do gentle stuff first?
Inevitably, it's just a training program. If I want to run a marathon, I don't start running a marathon tomorrow. I build it up gradually. And exactly the same way, you just start off with something the patient can tolerate, nice, small, achievable goals. 30 seconds of, sort of gentle head movement, would be enough, for example. But it depends how they come to you. If they come in a wheelchair, you've got to do things sitting down. But if they walk into the clinic room, then obviously everything's in standing, and you gradually progress it.
Have you got any ideas on what would provoke that neuronitis in the first place?
Good point. We think that mostly it's just an activation of dormant virus. So probably something like the herpes or chickenpox virus, which is dormant in most of us, 70-80% of us have it, it's just sitting there. Every now and again, it flares up. And it typically seems to affect the vestibular nerve between the ear and the brain, because the nerve is one of the few nerves that runs through a bony tunnel, through the skull, very narrow tunnel. And therefore, it's a little bit more easily squashed if it becomes irritated. And if you squash a nerve, it stops working.
Yes.
So that's what we think is going on.
Lucy's brought up an interesting point. She says she's treated a number of cases that were emotional in origin. One notable one, she says, was unresolved grief that was manifesting as vertigo. And it took work from the therapist and herself to resolve it. Is that something you've come across?
Not so very often. Generally, always there's a pretty much clear physical trigger for these things. However, as I was saying, if any other sort of emotional event or insult, it's going to cause an increase in sensitization of the nervous system, and the nervous system just isn't going to work as well. It's going to be more sensitive, and relatively ordinary inputs going into the nervous system are going to get exaggerated or false outputs then. So that could well be triggered. Often these things are kind of, remember, hidden, they're masked because remember, we're dealing with common conditions. Yeah. So there may well have been an underlying vestibular problem which has been masked to some degree, and then it takes some emotional event to upset everything and make everybody, make you notice the symptoms again, I suppose. But,
and of course, there's a strong argument that we can't resolve any condition properly unless we address the emotional component, if there is one as well. That's part of the biopsychosocial model, isn't it? So
we are dealing with an individual. We're dealing with a person, not a disease. And this is something I sort of bang on about a lot. And there is no guide, there's no recipe, there's no sort of set prescription of exercise or interventions. You just have to base it all on the patient in front of you. Yeah.
Elvina's asked for clarification. She says, are you saying that oculomotor function is central and anything else is peripheral?
Depends which oculomotor function you're talking about. So for example, if you're talking about smooth pursuits, the ability to suppress a vestibular nystagmus through head movement, or a saccade or an optokinetic, these are all central pathways. If you're thinking about gaze stability, which is, say, ability to keep your eyes fixed on a target. As you move your head, your eyes should remain fixed on the target. That's a peripheral pathway. That's the vestibular ocular reflex. So depends on what you're looking at as to whether you're going central or peripheral. But they're very accurate and very reliable guides of function.
Yeah. And Kaz has asked that she's supporting a client that has had a relapse of their MS, and the main result is a balance problem with dizziness, which is compounding just about everything else. She seems to have lost a lot of proprioception, and Kaz has spoken to a neurophysio who said to stimulate her vestibular and proprioception system, but due to time constraints didn't explain the best way of doing it. Have you got any advice for Kaz? I'm guessing Kaz isn't in Aberdeenshire, so...
Number one, you just get them moving the head. Move the head and the neck. If you want to stimulate the vestibular system, move your head. If my head is rotating, turning, going upwards and downwards, then I'm generating vestibular inputs into the brain. Now, it kind of depends as to where the lady's or the patient's MS problems lie, in the sense which pathways are not working very well. Is it the peripheral nerve going into the brain that's not working well? Is it a central sort of MLF problem within the midbrain? So, yeah, it's very hard to be any specifics, to give any specifics at all. But basically, yeah, anything involving movement and of the head and the neck is going to be a good thing.
Right. Okay. Well, got something more specific for you here from Helena, who's very well informed on these things. Helena says, do you recommend particular rehab exercises once you've seen people, or is it all tailor-made? And Helena's thinking about variations of Dick's Hallpike maneuver or Dr. Carol Foster's self-treatment of BPPV technique, and have Cooksey-Cawthorne exercises been discounted? So there's quite a bit in there.
Yeah. Just to do the last point, first of all, Cooksey-Cawthorne, Cawthorne-Cooksey exercises are a recipe of what to do if you're dizzy. They're better than nothing, but generally you can be a whole lot more effective just by homing in on the couple of key things for the patient and adapting them as you go along with the patient. Inevitably, with Cooksey-Cawthorne exercises, the patient ends up with a whole list of things to do. They do them all. They gradually feel worse and worse and worse, and eventually they're sick, and then they stop doing the exercises. So they're not terribly useful. So no, I've always based the exercises on the client. For that reason, there isn't a particular set of exercises that you should give. You just have to look at what the client is struggling with. But as I said earlier, I think I like to start by assessing the patient and then looking for dysfunction. So anything which appears to be dysfunctional, and I tend to start with the oculomotor function, but then also looking at just the more ordinary balance type of things as well. So any dysfunctions, we'll work on that. And anything which provokes a symptom response, I'll work on that as well. And then the fun is how you progress those, because you have to obviously keep on progressing them to keep on engendering change. So that was that. And then
the other was Dr. Carol Foster's self-treatment of BPV.
So BPPV is perfectly treatable by the patient themselves, because you just have to move the head through a certain set of positions depending on the canal that's involved and depending
which is the Epley maneuver.
And Epley is one of those maneuvers. It depends on which canal. Epley is for the posterior canal, or supposedly perhaps an anterior canal as well. But there are other maneuvers which are just as effective. For example, if I have someone who has come to see me, but maybe they live a long way away, or maybe I've tried them, I've seen them a few times, and yes, the treatment helps, but it keeps recurring, in which case I want the patient to be self-treating. Then often, rather than an Epley, I will tend to give them a Simont maneuver because it's simpler than an Epley. It only has 2 positions as opposed to 3, and it doesn't involve tipping the head back into such a sort of extreme extension rotation position. So it's a little bit safer for most patients. So yeah, you could give that. I think a lot of people get given these things called Brandt-Daroff exercises, which again, for treatment of BPPV. But I have to point out that for BPPV, they're absolutely useless. They are physiologically incapable of clearing crystals from the canals of BPPV. So
what were they called again?
Brandt-Daroff. And they're fairly typical. Brandt-Daroff. They basically involve sort of turning your head one way and lying down onto one side, and then coming back up and turning your head the other way and lying down the other side. And you repeat that. And all you basically do is you kind of slosh crystals from one side of the canal to another, and it doesn't really achieve anything. So if people get better doing Brandt-Daroff exercises, it's probably just time and giving them something to do whilst nature takes its course, which is nothing wrong with that. That's a good thing to do. But it's not the movement which is clearing the problem. So I wouldn't bother giving those. But some of these other self-treatments, yeah, as long as physiologically they're draining crystals out, then yes, they're fine.
You and I spoke a few days ago about the courses that you run. How long does it take to train a physical therapist, whether chiropractor, osteopath, or physio who doesn't have your specific expertise, to be competent in providing bespoke vestibular rehab exercises?
One day, one of my courses.
That was what I was going to ask, and I was hoping we might tempt you to come down here and run one of those one day, because I think a lot of people will be interested. We've
Yeah,
got a few people short of 500 watching the show today, so there's clearly a lot of interest in what you have to say.
I think the important thing is it totally depends on the individual, doesn't it? I mean, I know therapists who've been on 2-week courses in the States with renowned international experts and got all the badges and ticked all the boxes, and they're still useless. Whereas I know people who have never been on any of my courses who are really switched on, really engaged with the patients, and they achieve great things, even if they don't understand exactly what they're doing. So it's much more dependent on the individual. It's down to your attitude and your clinical reasoning and your decision making.
Yeah. Do we get a badge if we come on your course?
I could give you one. I can make a yes. Sure.
Another question this time from Amanda. Amanda says, my mum had years of dizziness, and after a fall where she broke her hip and wrist at home, the hospital carried out a full review and concluded she should come off all of her BP medication. She'd been on it for years, and I'd queried side effects with her GP, plus her BP had become much better with healthy diet-related weight loss. As soon as she stopped her meds, the dizziness went away and hasn't returned. BP's monitored at home. New GP says subsequently prefer to run elderly patients slightly higher rather than aiming for 120/80. Well, of course, yes. Wish the previous. So, I mean, what is the pharmacological implication here?
It's generally get the patients off the medication. I mean, we say dizziness gets worse as we get older. As we get older, we collect more and more drugs. Every drug has dizziness as a side effect, particularly as your colleague mentioned, the blood pressure things is crucial. Lots of the elderly are on way too high blood pressure medication, and they stand up, they get dizzy, they fall over. And the other issue is, a lot of these people they have a dizziness which may be multifactorial, as if they're 80 plus, lots of things going on. They become dizzy, and they get put on the vestibular suppressant medication as well. And this is the prochlorperazine and the cinnarizine and the beta histines and all these things. And these are the patients who most need their vestibular systems to work, because their vision's not very good and their proprioception's not good and the balance isn't good. They need that vestibular input, and yet we're blocking it with the medications. So it just doesn't make sense to me.
No, okay. Very quickly, a couple of other points here. Nikki says, I wonder how much of this aging experience is also affected by the primary or primitive reflexes that have re-emerged again, i.e. we stop doing specific movement patterns. Is that something that rings a bell with you?
Yes, I mean, I tend not to get too much into reflexes. The vestibular response is basically like a tonic neck reflex. If I turn my head to the right, I will get an extension on that side, and that is masked, isn't it, as we develop from newborns, or rather suppressed. And I think basically it's more to do with how we move, and if we stop moving, if we stop stimulating the system, then it's going to cause problems. Right. And I think that's kind of probably more the way to think about it, rather than worrying too much about the reflexes in terms of the vestibular system. We just think, get it active, stimulate it. Like any system in the body, it needs stimulus. And if you stimulate it, it'll work better, and overall then will function better.
Caroline says, do you use laser pointing exercises?
I do, yes, sometimes. I'm always trying to think about what's the main component to my patient's dizziness. So is it more vestibular, in which case we'll concentrate on head movement? Is it more visual, in which case, we're going to use more visual stimulus and optokinetic kind of stimuluses, or things going by the vision, or complex backgrounds? Or is it more proprioceptive? And a lot of the times it is proprioception to some degree. And most of the chronic dizzy patients you see will have bits of all of those going on. And you've got to say, okay, this week, what's the main component? And this week it might be proprioceptive, so in which case let's work on some improving the proprioception, and that may well involve, training head movements again using laser.
And we probably don't have time to go into this, but HG says, I've come across patients with VBI with loss of sight, and those cases were associated with extreme stress, which resolved over time, and wants to know what proportion of dizziness is stress associated. But we talked about emotions a little while ago. So
generally, I mean, stress is always linked with dizziness. They go together. But the thing I always am very, very at pains to take care to explain is that patients are stressed and anxious because they are dizzy. They're
Yeah.
generally not dizzy because they are stressed and anxious, okay? So
Yeah.
dizziness almost invariably will have a physiological, physical trigger, physical background to it. That's why they're dizzy. Because it hasn't got better, they become very anxious, highly distressed, disabled, depressed. All these other emotional states will start
Sure.
firing in. And of
Sure.
course, that feeds back into the problem and amplifies the signals
Yeah.
and amplifies the symptoms. But invariably, if you get rid of the dizziness, all those emotional problems disappear.
Yeah.
So
Thanks.
most people are anxious because they're dizzy, not dizzy because they're anxious.
Yeah. Alan, thank you for that. We've just tripped over the 500 margin. We've got more than 500 people watching the show at the moment, and it just shows the level of interest there is in this. And if we can get you down to run a course, we'll see how many people we can get to come along to it. I think it would be very, very interesting, very, very attractive to people. Mike, I'm sorry I've missed your question out about deafness, but I will put that to Alan after we've wound up here. I think it's probably outside the scope of today's discussion anyway. But Alan, thank you very much indeed, and hopefully we'll see some more of you perhaps next year.
Yeah, very happy to get involved again. Yes, thank you.
That was great. Thank you.